The screen is yours.
Okay, thank you very much, Fetty. I'll just share my screen. Good evening, ladies and gentlemen. So, as Fetty said, this will be an opportunity to learn a little bit more about papilloedema. I've been very, very lucky to work with 5 or 6 different ophthalmologists and neuro-ophthalmologists over the last couple of years giving this presentation, and I've learned lots of tips that I'd like to be able to pass on to you. And a lot of the feedback I get from optometrists after watching these presentations is it gives them a bit more confidence going into their practice room tomorrow or next week, knowing what to look out for signs and symptoms. So if you're looking at a fundus appearance tomorrow for your patient and you do see something like this, you might be aware that something is wrong, but you may not necessarily know why. You might see that the optic disc doesn't look normal, and by the end of this presentation, I'll have given you lots of different signs and also some symptoms to be able to watch out for, which are associated with papilloedema. So a lot of people come to us complaining of headaches, and sometimes they may jokingly say they feel they have a brain tumor. There's lots of people in social media at the moment that have brain tumors too as well. Joe Biden, the American president, he had a son who died at 46 years of age with a brain tumor. Taylor Swift's mother is living with a brain tumor, and we do hear people talk about it quite a lot. Something you may or may not know is approximately 1 in 3 people with a brain tumor will have visual problems. And that can be at the very beginning of the journey or secondary to the treatment, or when they're rehabilitating, they can have vision problems. But brain tumors can cause papilloedema, but they're extremely rare. You may have 1 brain tumor in your whole career. You may be unlucky to have 2 in 1 week. But most papilloedema is not caused by a brain tumor. It can be caused by other conditions such as hydrocephalus, meningitis, encephalitis, etc. So I want to start just talking about the classification of papilloedema, and this is quite an important one, because among ourselves, among optometrists, we can talk about papilloedema, but when we begin to commence talking to ophthalmologists, they want it to be referred to as suspect papilloedema, that we cannot diagnose papilloedema until intracranial pressure has been measured. So if you are discussing this with an ophthalmologist, it's always going to be a suspect papilloedema until intracranial pressure has been measured. The majority of papilloedema do tend to be bilateral. You can get very rare occurrences where it can be unilateral, and also the level of swelling can be different between the 2 eyes too as well. So one optic nerve may appear a bit more swollen in comparison to the other one. The important part with this is that all patients with a papilloedema should be suspected of having something, what we call an intracranial mass. You may come across a space-occupying lesion, something inside the head which is not normal, and that can be a lump, a bump, a bleed, or a tumor. It's always secondary, so papilloedema secondary to meningitis, papilloedema secondary to hydrocephalus. It's never a primary condition. The incidence in the UK is approximately 9.4 per 100,000. It may not seem a lot, but when I started giving this presentation 3 years ago, the number was approximately 2.4. So it has nearly tripled in 3 years, more than tripled. And we've gone through a pandemic where we weren't allowed to go outside. We were probably eating a little bit more, drinking a little bit more. And as the levels of obesity increased, the levels of papilloedema increased too as well. So this is quite an important slide because it contains quite a lot of information about the typical person that we're going to see with papilloedema. So approximately 80% of people with papilloedema do have idiopathic intracranial hypertension. Now, you may have known it as benign intracranial hypertension in the past, but the nomenclature, the wording has changed. So now it's IIH, idiopathic intracranial hypertension. And when we look at the classical phenotype, the type of person who gets this, the majority tend to be young females of childbearing age. 32 to 36 would tend to be the common age, and they tend to have a higher than average BMI. And one of the important aspects of this slide or this screen is 90% of them will be symptomatic, okay? So they will complain of symptoms I'll address in a few moments, but it's very, very rare to find somebody who is asymptomatic, and that's very, very important. So the majority of people will have symptoms, and also 90% will be obese too as well. So we're going to talk about some of the signs and symptoms that we routinely look at in an eye examination. Some may be able to help you, some may not be able to help you. Some people may come to your practice because they've lost their glasses, they're going on holidays, they want to get some contact lenses or some sunglasses. They may have symptoms, they may not have symptoms. In the early stage of papilledema, somebody could have perfect vision, 6, no problems whatsoever, no symptoms. But as I said, the majority do tend to be symptomatic. A visual obscuration called a transient visual obscuration, or abbreviated to a TVO, tends to be very specific to a papilledema, and I'll address this later in the presentation. And this is just due to a squashing of the blood vessels, stopping the oxygen getting to the eyes. A couple of things that we routinely measure, but you again may not get a response with early papilledema, is pupils, that you would get an RAPD, but you may not get it until later stages. Color vision is, again, routinely measured in hospital. I've been very lucky to give this presentation with different ophthalmologists. They all use Ishihara. I'm not saying Ishihara is the best color vision technique, but it's small, it's portable, it can be used for both children and adults. And what you're looking for is basically a monocular check of the color vision. Is the color vision affected? Record the severity, and then at each visit, record it again. So you don't have to talk about the sensitivity of the color vision test, just is there a color vision defect? Double vision, again, is very, very important too. It's a medical emergency. You're going to refer somebody with double vision anyway, but sometimes people with double vision, you may be thinking about, is it caused by an overacting muscle? And it could be further back in the brain, what we refer to as a false localized lesion. And the cranial nerve 6 tends to be the longest cranial nerve, and its point of attachment from the midbrain, the pons, all the way to the side of the eye. So therefore, it can be a bit more prone to from pressure, and that could be from direct pressure or indirect pressure, and therefore it causes a nipping or a pinching of the nerve, which causes that double vision. So especially in a child or an adult with a newly acquired strabismus or newly acquired sixth nerve palsy, you might be thinking, which is the overacting muscle or which is the underacting, but it could be just a little bit further back. So when we are looking at the optic nerve head appearance, it does tend to have very, very simple characteristic features. And it tends to be, first of all, very blurry disc margins. They don't tend to be distinct. They don't tend to be sharp. And one of the kind of first clinical pearls I want to pass on this evening time is a decrease or an absence of the C to D ratio. So papilledema is the opposite of glaucoma. So in glaucoma, the C to D ratio will go from a 0.2 to a 0.4 to a 0.6. In papilledema, it goes the opposite. It goes from a 0.6 to a 0.4 to a 0.2 as it gets filled with exudates. So you get a decrease of the C to D ratio. So very important if you do have previous photographs to compare it against. If you've got a previous digital camera image and you can look at it and then you see today's image, the C to D ratio is very smaller, that can confirm your suspicion that it could be dealing with a papilledema. One very important feature is vessel obscuration, and some clinical papers would tend to say this is the number one feature that papilledema has in comparison to other forms of optic disc edema, such as AION or NAION or optic neuritis. And I've got a lovely slide presenting this next. We're going to talk about flame hemorrhages. You may see flame hemorrhages either on disc or off disc. And also going to discuss the absence of spontaneous venous pulsation. Now, this is quite a controversial topic. Some ophthalmologists like seeing SVP, the spontaneous venous pulsation. Some ophthalmologists don't tend to rate it. It just used to be that 80% of the population would have SVP, and people used to think, well, if somebody has SVP, they can't have papilledema. But we'll discuss this later and discuss the controversy around it. This is an image of the obscuration of the blood vessels. So we can see here, this is a very subtle blurring of the disc margin. We can see the off-disc hemorrhages. And what I want to bring your attention to is the obscuration of blood vessels at the 5 o'clock position and the 7 o'clock position. So they just tend to momentarily disappear. And if you can imagine a flat optic nerve and the blood vessel coming off the optic nerve onto the retina, it just tends to be quite a straight flat line. If you can imagine that optic nerve becoming elevated or swollen, then the blood vessel's got to come off the optic nerve back onto the retina. So you do tend to momentarily lose it for a millimeter or two. So this is the obscuration of blood vessels that can be witnessed. And as I said, some people would rate it very highly, that it doesn't tend to be seen in other forms of optic disc edema. Visual fields is another check that we can do, and sometimes it can reveal papilledema, sometimes it can't, depending on when the patient comes into. So if you think about the mechanical side effects of a papilledema, if the optic nerve becomes bigger, larger, then the blind spot is going to become enlarged. So the first visual field defect is an enlargement of the blind spot. Then what's going to happen is an inferior visual field defect. So the superior aspect of the optic nerve tends to be affected, leading to an inferior visual field defect. And then after the inferior visual defect, you tend to get an overall constriction or reduction of the peripheral vision. So I've got an image here, some grayscale plots of an early papilledema, a mild or medium papilledema, and a late papilledema. So we can see in the early papilledema, we have the enlargement of the blind spot. Then in the medium, we tend to have the enlargement of the blind spot plus an inferior defect. And you can see it can sometimes mimic a glaucoma because it does tend to respect the horizontal midline. And then in a late stage papilledema, we tend to get an overall constriction or reduction. And depending on how quickly we get to these people and treat their papilledema, there is a good chance that the visual field can return, but it may not return in some people. OCT is becoming very, very popular now, and it's been used as what we call a surrogate marker for papilledema. And the majority of practices would be expected to have an OCT. If you work in a practice that doesn't have an OCT, don't worry, I'll give you lots of clues, lots of symptoms and signs to watch out for. But OCT has now been used here in the UK as a surrogate marker. So these young females who go to hospital, they need to have a lumbar puncture, and that can sometimes have risks too as well. And if they're going back every 3 months, every 6 months for lumbar puncture, that has associated risks. So now they're looking at the sensitivity of the OCT, and they're saying that the OCT can be just as good as a lumbar puncture in the measurement of the ICP and the management of these girls with papilledema. When we look at the OCT features, again, they tend to be quite mechanical. If you can imagine the optic nerve becoming bigger, larger, there's going to be an increase in the optic nerve head volume. Around the optic nerve, the peripapillary area is going to be much more thicker, much more bigger, and that tends to be a clue. And then what's becoming very popular now is the macular ganglion cell inner plexiform layer. So a lot of ophthalmologists I've given this presentation with would openly admit sometimes we can't tell by looking at the optic nerve. We just cannot discern it. It can be diagnostically difficult. And what do they do then? They look at the macular ganglion cell. So it tends to be very, very sensitive, not just in papilledema, but also in conditions like glaucoma. In optic neuritis now, they're saying that the very first signs can be witnessed in the macular ganglion cell. And then a very, very well-known sign of papilledema tends to be the forward bowing of the Bruch's membrane retinal pigment epithelial complex. I'll just show you the next 1 or 2 slides. So this is the forward bowing of Bruch's membrane. These are 2 papilledema. So we've got a papilledema on the right-hand side, and we have a papilledema on the left-hand side. This is the Bruch's membrane here, okay, and it should be quite straight. In theory, they might be slightly curved downwards. But what tends to happen is when you have papilledema, there's pressure from below, and the Bruch's membrane moves upwards. Approximately 2/3 of people with papilledema would have this appearance. So we have an upward bowing of the Bruch's membrane. Like a drawbridge in a castle, it just moves upwards. And this is from the pressure from below. So this dark area here is fluid. This is edema, and it just causes the pressure of the Bruch's membrane to move upwards. Sometimes it doesn't move up, and this is approximately 1/3 of people with papilledema. So you can have papilledema with a forward bowing of Bruch's membrane in 2/3 of the situation, and you can have people with papilledema that don't have the forward bowing. It can be quite straight. So again, the majority of people will be like this, but you can also get a papilledema where there isn't any forward bowing. This is the very, very popular, very sensitive area for looking at signs of papilledema in the macular ganglion cell thickness. And what tends to happen is there's a thickening superiorly nasally, and inferiorly, and the temporal area is left unaffected. And this is something I want to be able to tell you is quite important, because when we look at a different photograph, again, the temporal area is always the last area to be affected. So people always ask me, which is the first part to be affected? Is it superiorly, inferiorly, nasally? And it's nearly always last to be temporal. So it's superiorly, nasally, inferior, and then temporal area. If you look at the thickness profile of the macular ganglion cell, this tends to be the most sensitive area here, the nasal area. And the magic number tends to be 86 microns. So if you have a measurement thickness of 86 microns or higher, then there's a very strong likelihood that could be a papilledema. If the thickness profile in the nasal quadrant tends to be 86 microns or below, then it's more than likely a pseudopapilledema. But this is quite an important image just to remember, because we'll come across this later. Now, some ocular conditions you could really kind of diagnose by looking inside the eye, and some ocular conditions you could probably have a rough educated guess even before you look inside the person's eye. And papilledema tends to be that, because 90% of them will be symptomatic, and the majority of symptoms they have would tend to be headaches. And the headaches they have are very, very strong enough to wake them from their sleep in the morning time. And something that's associated with too as well tends to be what's called a pulsatile tinnitus, or a whooshing noise. And this is a whoosh, whoosh, whoosh that the patient will hear themselves subjectively in their ear. And it's the blood vessels coursing through the blood. The blood coursing through the blood vessels, and they can hear it in one ear. And sometimes it tends to be synchronous with their heartbeat, and they'll tend to say it just goes whoosh, whoosh, whoosh. Sometimes it can have nausea and vomiting. And also you'll tend to find it's worse when they're lying down on their back. So when they're lying on their back, the CSF can't drain, and therefore you get a buildup of ICP. The headache intensifies. And then once they stand up and move around, the CSF can drain, the ICP decreases, and the headache decreases too as well. So people will sometimes say it's really, really bad when I wake up in the morning time, but once I get dressed and move around, it's okay. Or especially with a child who maybe isn't able to explain these vocal features, if they say the child wakes up in the morning time holding their head in pain, crying with tears, it's very, very serious. So the majority of headaches tend to occur first thing in the morning time, sometimes waking people from their sleep. So the transient visual obscuration is a full field momentary loss of vision, very, very quick, and it affects the full eye. And it's not to be confused with a loss of vision that can be associated with a migraine, or a loss of vision associated with an amaurosis fugax or a giant cell arteritis. It tends to be very, very quick. If you look at the papers, sometimes the papers will say it's like a graying out or dimming of the vision, but people will never say these words in your chair, in your testing room. So what you have to be able to do is be very careful with your questions and ask them a very direct, closed question, which will just give a yes/no answer. And you could say something along the lines of, has your vision just momentarily disappeared? Not a case of, has your vision gone blurry? Does your vision go blurry at times? Because people would say, yes, it does. But if you say very succinctly, very quick and short, does your vision just momentarily disappear? They could say yes. And again, this is something that they may not volunteer. You may have to probe for it. So if you go through history and symptoms and everything's okay, and then you look inside the back of the eye and you're concerned, maybe you could come back and say, have you had momentary loss of vision? If they say yes, again, that will increase your confidence that it could be a papilledema. When we look at the classification of papilledema, there's two classifications. One is called the Frisson scale, and the Frisson scale tends to be used in hospital, and they talk about a grade from a grade 0 to grade 5. So if you're speaking to an ophthalmologist, they may say we had a child with a grade 3 papilledema, or we had a lady in with a grade 5 papilledema. Some people don't agree with the Frisson scale, because the Frisson scale just looks at the optic nerve. And in a true papilledema, you'll have optic nerve changes, but you'll also have retinal changes. So a lot of clinicians, a lot of ophthalmologists and optometrists tend to prefer using early papilledema, established papilledema, chronic and atrophic. Now, obviously, these two are going to be emergency referrals. When somebody has an episode of papilledema, it's always good to know that the optic nerve returns to its normal architecture, its normal shape, but it loses that natural glossy glow. We just tend to be left with this dull pallor. So this is the one which causes the most concern, the most anxiety. People are scared. Is this a papilledema? Is it not a pseudopapilledema? And hopefully I'll give you lots of clues to guide you. So when we look at the early papilledema, the patient may come into you symptomatic. They could be asymptomatic. They may not notice anything wrong. When you look inside the back of the eye, depending on when they present to you, the optic nerve may be slightly more hyperemic. It might be slightly elevated. And again, people always ask me, which is the first part of the nerve to be elevated? And the majority tend to be nasal. So it'll usually be superior, inferior, nasal. Again, the temporal area is the last area to be affected. So if you look at somebody and the temporal area is raised or swollen and you think it's papilledema, it's not, because the temporal area is always the last area to be affected. The vessels can be quite bendy, can be quite tortuous, and something you may or may not have heard of called a C-shaped halo. And a C-shaped halo is really, really easy to show you and explain to you. And once you see it, you'll tend to never forget. So this is the C-shaped halo here around the optic nerve. So it's a back to front C, just in case you're thinking where the name comes from. So it's a C that's back to front, and it usually tends to affect the superior, nasal, inferior, and it tends to leave the temporal area unaffected. Now, we refer to this as an obliteration of the optic nerve or an obscuration of the optic nerve. This would be classified as a grade 1 papilledema. What tends to happen with a grade 2 papilledema is the obscuration or the obliteration would cover 360 all the way around. And then a grade 3 papilledema would be 360 all the way around with minor blood vessel involvement. A grade 4 would be 360 obscuration with major blood vessel involvement, etc. So that's referred to as a C-shaped halo. Then we move on to the established papilledema, and again, people may present either with symptoms or without. The majority will be symptomatic. They may have transient visual obscuration. Again, you may have to ask for it. They will see the C to D decreasing, as we discussed the opposite of glaucoma. The optic disc will become a bit more red, a bit more angry looking, and we'll tend to find hemorrhages, again, on disc and off disc. We'll tend to see signs of exudates and cotton wool spots, and this is where the Frisson scale doesn't tend to look at the retinal features, and this is the reason why some people don't like the Frisson scale, because it doesn't include the cotton wool spots or the exudates. And the other clue I wanted to point out to you is something called a Peyton's line. And a Peyton's line is basically stretch marks. Again, if you can imagine the optic nerve becoming larger, swollen, it'll tend to stretch the retina around it. And then we're left with these stretch marks called Peyton's lines. So these are Peyton's lines down here. And they tend to be on the temporal side, and they tend to be the superior temporal or inferior temporal on the side closest to the macula. And they can be quite easy to see on red-free. So if you do have a red-free facility on your slit lamp, on your photography, do put up the red free, you can see it. It's very, very easy. So again, this wouldn't be a normal finding. So the optic nerve is becoming bigger, swollen, elevated, and a stretching, and therefore the retina around it is stretching too as well. And just to bring you back to your human anatomy, if you were to look at the retinal nerve fiber layer, they tend to be arcuate and they tend to be vertical in nature. There doesn't tend to be any natural nerve fibers which are circulate or circular. So if you do see these, it's not normal. And this is a very prime example of superior temporal Peyton's lines and inferior temporal Peyton's lines. So again, just stretch marks for want of a better word. And then we move into the more chronic papilledema, and this is where the patient will definitely know something is wrong. The visual fields will be affected, and we talk about a champagne cork appearance. If you can look at the top of a champagne cork, it tends to be quite curved or bulbous, like a mushroom. So if you do a fundoscopy on 3D Voke, you'd probably see the optic nerve coming towards you with that champagne cork appearance. And again, there tends to be retinal features that the Frisson scale doesn't tend to include. And then in the last stage, the atrophic, the optic nerve just looks very dull, very lifeless. It tends to be what we refer to that kind of grey pallor. It tends to lose its colour. And unfortunately, the prognosis doesn't tend to be as good. The visual fields are usually compromised and the visual acuity is affected too as well, which may or may not return. So as we mentioned, there are some clinicians who don't like the Frisson scale, and some clinicians would tend to say for a true papilledema, you have to have these obligatory signs or compulsory signs. You have to have a subretinal fluid. Sometimes you may see a macular star, and a macular star tends to be that firework presentation of white exudates we tend to see. Sometimes it looks like a malignant hypertension or a form of optic neuritis, a neuroretinitis, and you just tend to see this macular star. But again, you may see macular hemorrhages and the retinal features of cotton wool spots and exudates and patent lines. So as we mentioned at the beginning, SVP tends to be quite contentious. I've given this presentation with some more mature ophthalmologists and some younger ophthalmologists. And the more mature ophthalmologists tend to like it because when they were in college, they were told, if you see SVP, the person cannot have papilledema. But the younger ophthalmologists don't tend to agree with that. They don't rate SVP. And the reason being that there was a very famous study done by a neurologist and neuro-ophthalmologist in Moorfield, and she was looking at these young ladies coming down for suspect IIH, and just before they had the lumbar puncture, she was measuring to see if SVP was present or absent, and she found that 86% of them had SVP who did actually go on to have papilledema. So a lot of the younger ophthalmologists would tend to say, yeah, we don't tend to use it because of that. But just to let you know, the ophthalmologist may ask you if you're on the phone to them, do they have SVP? Is SVP present or absent? And what is SVP? So it's a spontaneous pulsation of veins in the center part of the optic nerve, and it's caused by a differential. Usually the pressure inside the eye tends to be higher in comparison to the pressure in the optic nerve. And what tends to happen with a papilledema is the pressure in the optic nerve increases, and therefore you tend to lose that the pulsation. So you're going to refer people to hospital. What are they going to do in a hospital? So for the checking for the hospital, they're going to do non-invasive testing first of all, and they're going to do some ultrasound testing, and they're going to do two methods. Ultrasound A is measuring the diameter of the optic nerve sheath. So just to bring you back to your anatomy, the optic nerve is covered by the optic nerve sheath. If it becomes edematous with fluid, it's going to become larger. So they measure the diameter of the optic nerve sheath, and if it's 2-3 millimeters, it's classified as normal. Once it gets 2, 4, 5 millimeters, that would be too big, and they know it's a papilledema. What used to be classified as the gold standard up until recently is the ultrasound B, and the ultrasound B is very, very sensitive. Some papers would tend to say just as sensitive as an MRI scan in detecting papilledema with a 92% success. What will tend to happen is, depending where the patient goes, they do need to do some neuroimaging, whether that be an MRI scan or a CAT scan, and they'll do two scans, one to check to see a space-occupying lesion, a lump, a bump, a tumor, and they'll also do a check to see if there's a bleed in the back of the eye, or sorry, a bleed in the brain, what we refer to as a venous sinus thrombosis. So they'll either do two CAT scans or two MRIs. At that stage, even the ophthalmologists sometimes say, I still don't know. What are they going to do next? They'll do a fluorescein angiography. So with a papilledema, because there's a break in the blood retinal barrier, you'll see exudates coming out. In a pseudopapilledema, you wouldn't see it. And then they'll also use OCT. This is the ultrasound B I was chatting to you about. So this is the vitreous humor, the vitreous cavity, and this is the crescent sign here. So just in between the white arrow and the red arrow, it looks like a horseshoe or a crescent, and this tends to be only indicative in a papilledema. So very, very quick, very, very sensitive and non-invasive. So it can be very, very quick for a very good diagnosis. So now we've mentioned papilledema, we also need to mention pseudopapilledema. And when we talk about papilledema, we tend to have people who are young females who are higher than average BMI, and they tend to be 90% would be obese. So we have a general picture of the typical people who come in. But sometimes people would come in and their general health is quite good, and we look inside the back of the eye, and sometimes we are a little bit suspicious. And if we think, well, is that person, you know, a candidate for IIH? Because if you were to phone up an ophthalmologist here in the UK, sometimes the first two questions they say is, what's the sex of the patient, or male or female, and also are they overweight? Because they're trying to to find out too as well if the person has IIH. And some of the associated symptoms or signs with IIH would tend to be a sore neck, difficulty with the shoulders, feeling dizzy, and also maybe trouble walking, their balance, their gait is affected. So somebody might say they've got an unremarkable history and symptoms, but you could by asking them, you know, sore neck, feeling dizzy, etc. And you're just probing, do they have possible IIH? Weight gain is something that is very sensitive to ask somebody, and people may not mention it to you. So nowadays we're talking about most practices being multimodal. So we're using digital retinal camera, we're using OCT, visual field to get as much images together like pieces in a jigsaw, to put them all together to guide our referral to say, is this person a candidate for papilledema, or is it a pseudopapilledema? So when we look at pseudopapilledema, there tends to be 5 main culprits. And if we look at them, optic neuritis, AION, optic nerve head drusen or optic disc drusen, tilted optic disc, and congenital crowded disc. Now, the bottom 3 tend to be the most popular. The top 2 tend to be the least common. So if we look at the first 2, first of all, and if you look at optic neuritis and AION, they'll tend to affect one eye. They tend to be unilateral, but the majority of people, as we said at the beginning, tend to be bilateral. The onset of optic neuritis and AION tends to be very sudden, very sharp, very acute. The person will be able to remember, while people with papilledema won't be able to remember. The loss of vision with an optic neuritis and an AION, again, is very sharp, very quick. With papilledema, it's not. And then if you look at the disc swelling, depending on the type of optic neuritis, the disc might be swollen in the papillitis or neuretinitis, and you'll tend to get a very definite marked swelling in the AION and the papilledema. With optic neuritis, there can be a varied field defects, more diffuse more than anything else. The AION tends to have a very typical hemi-altitudinal visual field defect. And as we discussed already with the papilledema, it tends to start with an enlarged blind spot, followed by an inferior defect, followed by an overall constriction. And pupils tends to be very important. As we said at the beginning, you may not get an RAPD in a papilledema until a late stage, but you will definitely get an optic neuritis RAPD and an AION RAPD. So the number one reason we get it wrong in pseudopapilledema is optic nerve head drusen. And depending on your level of experience and where you're working, if you're working in a high volume practice, you may come across optic nerve head drusen quite a lot. If you're working in a small volume practice, you may not see it, but it's very, very normal. And it tends to be bilateral in the majority of cases. And it's congenital, tends to be affecting Caucasians more than anything else. And some papers would tend to say they're more located nasally, temporally, superiorly, inferiorly. But with the advent of OCT technology getting better and better, we're now talking about something called enhanced depth imaging being the number one, the gold standard technique for detecting optic disc drusen. So as the technology is getting better, we can go deeper into the optic nerve to see where these optic disc drusen are. And when we look at the optic disc drusen, there tends to be 2 different types. We talk about visible, which are on the optic disc surface. We can see those, they're easy. The more difficult ones are the hidden ones, or buried optic disc drusen. We can see them. And when people are born, the optic disc drusen are at the very bottom of the optic nerve, and it takes 20, 30 years before they migrate up to the very top, or they become visible. And during that 20, 30 years, they can cause vision problems, they can cause visual field defects, they can alter the axons in the optic nerve, leading to these visual field defects. And also they can sometimes mimic glaucoma. So if you have somebody coming into your practice, you say that they were attending an ophthalmologist in the past and they were taking glaucoma medication, but now they've stopped, that could be because they had optic disc drusen. So years ago, it used to be assumed that for the treatment of optic disc drusen to use glaucoma medication, but it's not used that often anymore. One of the clues for the detection of papilledema is the anomalous branching of the blood vessels. And again, if you're not too sure what it is, once you're shown, it's very, very easy. And it just takes 1 or 2 more minutes looking at the optic disc to find out where the branching is. So if you look at the wording tends to be interchangeable. It can be optic nerve head drusen, optic disc drusen, drusenoid disc would tend to be the same. Moth-eaten would tend to occur in about a third of people with optic disc drusen, and it just tends to be like a moth has come along and just kind of nibbled away at the edge of the optic disc, and this we refer to as atrophy, the moth-eaten atrophy. We Not to get confused between drusen at the optic nerve and drusen at the macula. So the drusen at the optic nerve tends to be hyalinized, calcified material, which is very, very hard, brittle. And the drusen takes this name from a German word for rock. So what tends to happen is it's very, very hard. And when the blood vessels come to these drusen, so there's a drusen here, there's a drusen here, and here, and here. What tends to happen is when the blood vessel gets to the drusen, gets the rock, it can go through it. So it's got to go around it and deflect. So you can see with this blood vessel here, it starts off in one direction and then boom, it changes 90 degrees, okay, and just goes in a totally different direction. Why? Because it can't go through the optic disc, the optic drusen. This is a slightly more difficult one to see, but again, you can see a large optic disc drusen here, and you can see hypo and hyper reflections down here. And again, this is a bifurcation of the blood vessel. So why is the blood vessel turning into two? Because the blood vessel can't go through the drusen, so it's got to go divide into two or go around it. So just by spending 1 minute looking at the blood vessels and looking for these changes in their direction, looking at these bifurcations, they can be clues to say, is this a pseudopapilloedema or is it a papilloedema? Again, how do they diagnose the pseudopapilloedema in hospital? They'll use the ultrasound B, and the ultrasound B will tend to show a hypoechogenic sign that the optic nerve head drusen contains calcium, and the calcium would tend to glow in an ultrasound. A normal optic nerve head wouldn't contain these features, so that's what they tend to do. So a bit like our calcium in our bones, we have an X-ray, it makes the bone shine, and same with the optic disc drusen, they tend to shine. And I'm not sure if you have an optos, but if you have an optos and you put somebody with optic disc drusen, it just tends to glisten and shine like Christmas trees. So they're very, very easy to see. The second most common reason for a pseudopapilloedema is a tilted optic disc, or another term is a bilateral tilted disc syndrome. And this again is very, very normal, happens in a lot of myopes. And what tends to happen is it just tends to be a slightly oblique insertion of the optic nerve. And what does that mean to you and to me? It just means the nasal part of the optic nerve appears closer and the temporal part appears further away. And we tend to get a bit nervous because it looks like a papilloedema. The majority of people do tend to be associated with myopia, but you can get people who won't fit that description. They can be hyperopic too. So this is the tilted optic disc. The nasal portion appears closer to us. It appears larger. We tend to find that the temporal area tends to be a bit more further away. But if you see signs we've already discussed, such as the C-shaped halo, is there a C-shaped halo here? No. Is there any signs of Peyton's lines? Again, no signs of Peyton's lines. With the papilloedema, we have a C to D ratio that's decreasing. We obviously have a very large C to D ratio here. So again, is the patient symptomatic, asymptomatic? And with this one, it can be quite reassuring not to see these. And also, it's quite important to be able to document the negative findings as well as the positive findings. For medical legal purposes, you might kind of think, well, that's okay. I'm not going to refer them because they don't have them. But to document that in your patient records, they'll say not referred because it looks like a tilted disc. They don't have a C-shaped halo. They don't have Peyton's lines. The patient is asymptomatic, etc. And it just means if somebody is coming in after you and looking at your patient, they'll think, well, why wasn't the patient referred before in the past? And if you can document that, the negative findings, I didn't want to refer the patient because they didn't have this, it will be a very, very good documentation. And the third most common reason is a congenital crowded disc. And again, very, very normal appearance. And again, if you work in a high volume practice, you'll come across it quite a lot. And again, it's very normal in our hyperopic population. And it just means the optic nerve is a bit more smaller, therefore appears a bit more crowded. It tends to be a bit more hyperemic, and therefore we get a bit concerned. There tends to be a very small or absent C to D ratio. And again, we get concerned that it could be a papilloedema. So one way of one way of trying to aid you with this is by measuring the optic disc. So if you have a Vogt lens, you could actually just measure the vertical size, and also the horizontal diameter, and ask the patient to return to at another time, maybe 4 or 5 days, a week later, and measure them again. And obviously, if the numbers are getting bigger, then it's going to be a sign of a papilledema. If the numbers are just remaining the same, static, then it's a pseudopapilledema. But again, you can see why people get a little bit concerned, because the margins don't tend to be perfectly clear. It tends to be slightly hyperemic, and the C to D ratio is very small. So again, just to kind of go back and why to the hospital, what do? They use the ultrasound B just to look at it. So a normal optic nerve head doesn't have that reflectivity. It just tends to be quiet, while the optic nerve head drusen does have very hyperreflective. It tends to shine and glisten. And also too, as well, we tend to use that non-invasive ultrasound B, and it's extremely sensitive, 92% sensitivity. This is becoming very popular now too as well, the fundus autofluorescence. Now the fundus autofluorescence is only good when the optic disc drusen are at the top of the optic nerve, when they're visible. So at the present moment, the fundus autofluorescence can't go any deeper than the layer, but hopefully with technology and the advances in OCT, we might be able to use that to detect, especially in children with very blurry disc margins, we should be able to see the optic disc drusen a little bit quicker. So if you do have a previous photograph of the patient and comparing the previous digital image versus the image today, that can be very, very good too as well, to be able to compare them. And I've got a lovely photograph coming up next to do that comparison. And OCT can be your friend at times. Sometimes it can be your enemy. Sometimes it can say to you there's something wrong, but there's not. And unfortunately, a lot of the OCTs tend to use Caucasian data sets, and also for normal prescriptions. So if you work in an area that doesn't have a large Caucasian population, or they're quite large prescriptions, the OCT may say to you there's a problem, but there's not. So the best way is to use your patient as a control. So get the patient to return at another time, in a week's time, and repeat your measurements, repeat the OCT. And if the measurements are the same, then you know it's pretty good. So this is the advantage of having a pre-papilledema photograph and a papilledema photograph. So you can see in the pre-papilledema, the large C to D ratio, and then in the papilledema photograph, we lose the C to D ratio. We can see the C-shaped halo developing superiorly, nasally, and inferiorly, and then it tends to go all the way around circumferentially. So that tends to be a very good idea of having a previous photograph to go by. But if a patient is new to your practice, you may not have that facility. So coming towards the end of the presentation, some people always ask, well, how can I tell if it's an optic nerve head or if it's a papilledema? And again, if you look at the patient who comes into you just for a routine eye examination, if they have optic nerve head drusen, will they have symptoms? And again, some papers would tend to say some of them may have symptoms, some of them may not. While the majority of people with a papilledema, as we said, 90% will be symptomatic. And also you might have to ask them for the transient visual obscuration. So you can say to them, I want to ask you a very simple question. Has your vision just disappeared momentarily? Yes, no. You can also ask the same about the pulsatile tinnitus, and this is something I forgot to mention to you. So when somebody has the pulsatile tinnitus, the whoosh, 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 they won't explain it to you. They won't disclose it because they think, well, why should I? It's got nothing to do with my eyes. But if you're suspicious, you could go back and ask them. And again, in a very closed, direct question, I want to ask you about your hearing. Do you ever hear a whooshing noise in your ear? And again, you're looking for a yes, no. And if they say yes, again, it would increase your risk of suspicion. Optic nerve head drusen can sometimes have visual field defects, and sometimes they can mimic glaucoma, like the papilledema. But with the papilledema visual field defect, it tends to be an enlarged blind spot followed by an inferior defect. Would you get double vision with optic nerve head drusen? Not really. And would you get headaches with optic nerve head drusen? Not really. But as we discussed, you would get a sixth nerve palsy with a papilledema. And the headaches would tend to have very characteristic features. They've been very, very painful. It's painful to wake you from your sleep, and also tend to find with nausea. And then the optic nerve head may appear slightly elevated, but would you get retinal features with an optic nerve head drusen? No, you wouldn't. With the optic nerve head, or sorry, with a papilledema, you'll tend to find Peyton's lines, C-shaped halos, cotton wool spots, macular edema, etc. And just the final slide tends to kind of be a very good one just to kind of memorize when you are in that moment and you think, is this a papilloedema? Is it a pseudopapilloedema? And you're getting concerned because the optic nerve head will appear elevated in both. But what tends to happen is think for a moment, what about the disc color? In a normal pseudopapilloedema, it's going to appear normal, healthy, glossy yellow. And a papilloedema is going to be very angry, very red. And then with the disc margins in a pseudopapilloedema are going to be very sharp. They're going to be very distinct, while the disc margins in a papilloedema are going to be very indistinct. They're going to be very lumpy, bumpy, blurry. And as we said, with the C to D ratio, it's going to be decreasing in a papilloedema, and it's going to remain exactly the same in a pseudopapilloedema. We already discussed the controversial issue of SVP. So SVP cannot be relied upon as a good indicator, but just be aware of the factor why. And then would you get hemorrhages in a pseudopapilloedema? Not really. Very rarely can occur in an optic nerve head drusen, but you would get hemorrhages with a papilloedema, and that can be both on disc and off disc. And again, the retinal features, would you have retinal features with a pseudopapilloedema? None. And would you have retinal features with a papilloedema? And the answer again is yes. Okay, so we got the cotton wool spots, the exudates, and the Peyton's lines, the C-shaped halos, etc. So that's coming towards the end of the presentation. So hopefully I've been able to give you some confidence. If you were just to kind of ask me for maybe kind of 1 or 2, 3 kind of clinical pearls to take away back to practice, headaches tends to be the number one. Okay, so the headaches would tend to be when they're worse when they're lying down. Are they worse when they have what we call a Valsalva maneuver? A Valsalva maneuver is when they cough or sneeze or sing or shout. It gets worse as there's an increase in the pressure inside the head. Asking them about the pulsatile tinnitus, it's a bit like picking up a seashell on the seashore and it goes shh in your ear. Sometimes it can be pulsatile, like your heartbeat, whoosh, 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 or it can be just a noise in the ear, and they will hear it, nobody else will. And just asking them, do you have that ringing noise in your ear? Same with the transient visual obscuration. It just tends to be a momentary loss of vision. It doesn't tend to last long. And just ask them, can I ask you a question about your vision? Has it just momentarily disappeared? And you don't want to get into a long conversation, just a yes or no. So I can happy to share my slide deck with any of the listeners, any of the attendees. And Fethi, please feel free to share them with anybody who asked them. And if anybody wants to ask me a question, please feel free to email me. And my email address is on the screen, and you can ask me any question and I'll get back to you very, very quickly. So thank you very much, Fethi. If anybody wants me to repeat any slides or go over any of the slides again, I'm quite happy to. There's no problem.
Thank you very much. It was a very, very full of knowledge presentation. I think that people are looking about the link between dramatic situations such as brain tumor and what they see in the optic disc of people will be examined by them. So the point is, we have been talking about unilaterality and bilaterality, unilateral or bilateral. As I think IIH and when ICP increase inside the brain, most of the time both eyes are affected, both optic nerves are affected. So what in your point of view is unilaterality or bilaterality? Is it a clue or a way also in suspecting or not a situation of
it's very important that the majority of people with papilloedema tend to have bilateral swelling, bilateral elevation. And it's very important to be able to differentiate between unilateral and bilateral, because there's another eye condition which affects exactly the same age group, which would be optic neuritis. So optic neuritis tends to affect young females early 30s, 32 to 36, and they would have symptoms too as well. But the symptoms would tend to be slightly different. But they would have unilateral swelling in one eye, while the papilledema girls would tend to be bilateral swelling. So you can get unilateral papilledema, but it does tend to be quite rare. I think looking at clinical papers, it tends to be quite high in the 90s that the papilledema is bilateral in 92, 93% of cases. So I would be saying the majority of people with papilledema would have bilateral swelling, and that's the clue to watch out for.
The second point is that through the presentation, I haven't seen a lot of information about what is happening at the macular level, GCC, thickness, and so on. So you have been focusing on optic nerve rather than looking at the whole retina and especially to the macula.
Yeah, the macular ganglion area tends to be very, very common, very popular at the present moment, because it's been used now for the screening of not just papilledema, but for optic neuritis, for glaucoma. So now they're saying that when somebody has glaucoma, even before a visual field defect, it can be detected in the macular ganglion inner plexiform layer. A lot of the artificial intelligence, which is screening now for Parkinson's, is looking at the blood vessels and looking at the cells within the macular area. And a lot of the ophthalmologists tend to concentrate on the macular area too as well, because the ophthalmologist will sometimes say, when I look at the optic nerve, I can't tell. I really cannot tell if it's papilledema or pseudopapilledema. Where do they look at? They look at the macular ganglion cell. So just trying to concentrate on that, maybe get, if you have an instruction manual from your OCT, maybe looking online and just kind of look at the macular ganglion cell inner plexiform layer and the thickness profile, because it does tend to be very, very popular at the present moment. So just if you aren't too aware of it, just spend a little time just concentrating on that.
Okay. So what's the what's the duty and the legal side of missing something happening in the optical optic disc without we have sometimes doing some misdiagnosing. That's because some people have a lot of background on looking at fundus and that especially at optic nerves. Some others are not willing or haven't got enough experience. What's the point for the optometrist who is a primary care practitioner? What's the point?
Yeah. So what tends to happen here in the UK is people would have to refer what they would think is a suspect papilledema to hospital and the hospital ophthalmologist. But sometimes people would just tend to look at an optic disc, which may just be a little bit different. It may be a little bit kind of abnormal because of a congenital situation, or it could be a bilateral tilted disc syndrome. And they just refer into hospital. And because there's no feedback, there's no communication from the hospital saying if it was a papilledema or pseudopapilledema, those people just continue to refer in. And it just tends to lead to a lot of anxiety for the patient and the patient's family. It tends to lead to a lot of unnecessary false positive referrals going to the hospital. Sometimes the ophthalmologist will tend to have very angry people coming to them because they look at the referral letter, they go online. If they're told that it's a swollen optic nerve or papilledema, they go on the Google and they think they've got a brain tumor. And then they can be quite aggressive to the hospital staff too as well. So here in the UK, we tend to be a little bit fractured. There's no system to give back the optometrist an idea of, of their success. Was it a papilledema? Was it not? And if the person isn't trained properly, they'll just continue to do so. They'll just refer to hospital, and it just tends to increase the waiting time, increases the duress of the patient, and increases the workload of the ophthalmologist in the hospital.
Okay, I have a feedback from an optometrist, an Irish optometrist, Linda McGivney Nolan. She said this was fantastic I am a neuro-optometrist dealing primarily with pediatrics. I spend my time obsessed with missing something in my kiddos. Have seen plenty of this DRUSEN in my past. I'd love a copy of the slides. So she could download it from our Facebook group. It's already on files. So she said that, because I have exchanged with her 2 days ago. She said that she attended one of your lectures and she was scared. She said, "Oh my God, that's the whole point. We can miss something, and also we have the possibility, the opportunity to detect something suspicious, and we need to send them." I think the fact that a lot of people now people are aware about the fact that they have the responsibility to find the wrong side of what is happening in the vision. So they're aware about their responsibility. So it's why they're sending a lot of people. And also that in my education, I think in my university education, we had kind of just 2 lectures on this subject. So we need to have more lectures about this aspect, because we have to be careful with when we are examining people, especially when we have headaches and vertigos and nausea and so on. We have to be aware, because sometimes we are just splitting between the wrong sides of the vision, and we are not looking at the health as we have to have a holistic approach to understand what is happening. And now with OCTs and with this retinal camera, and also with the visual fields, I think we have the tools to be able to not to be very far from the true situation, and the clues and the clinical tips which we have given us today are really important. We have to look at them carefully and to read them, and to see how we can, every time we have front of us someone who can fit this description, we have to examine carefully and to bring the right advice. Referrals, referrals is sometimes a good act, but sometimes it is also an act which we are just trying to push these people outside of our practice, to send them back in another place, because we are not sure about what we are doing. So we need to upgrade our knowledge about all these clinical sites, which seem quite complex, but really when we have the right clue, we can manage to get through.
Yes, and you made a very valid point about OCT, that the majority of practices now have OCT, and OCT can sometimes scare us and tells us that there's something wrong with us not, and we feel under pressure then to act upon it. But I agree with you, we have to upskill, we have to learn, and to get as much confidence about this condition as possible. And I'm always learning, and I've been given this presentation for a couple of years, and I change it, as soon as I learn something new, I try to pass it on to the practitioners. And happened to me at a conference, I met a Canadian lecturer, and he was asking me about papilloedema. His daughter had it, and I was asking the typical questions: was she overweight? Did she have headaches? Did she have nausea? And he was saying no, 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 no. And I was really baffled, and I learned that she had an atypical papilloedema. She had no symptoms, no problems, vision was perfect, visual field was perfect. It was only on OCT it was detected. So we do talk about the 90% who'll be symptomatic, the 90% who'll be obese, the 90% who'll fit this category of the typical, but also we can't forget about the atypical. And sometimes men can have papilloedema, and thin children can have thin ladies can have papilloedema too as well. So I was just trying to kind of paint a picture of what the majority of people would tend to have, but also we have to kind of, you know, think about the atypical, that there are going to be people who don't fit the category. So just being cautious to know that, you know, we're still learning and we still have to be able to be consistent with all of our findings and have a duty of care for all of our patients. If we're suspicious, get them to return to repeat your checks. And if you are suspicious, to refer them on to further evaluation.
Thank you very much. I think that we have had a great moment to learn from you, and I think that you have engaged with the brain tumors charity. It's a kind of involvement, human involvement, which is obviously very important for all. Saying that empathy is not enough. We have to help these people and to learn more. Thanks a lot. Thank you very much.
You're very welcome, Fethi. Thank you.
Bye-bye.
Okay, thank you. Bye-bye.